for this event. So thank you for coming, and we are grateful to Dr. Bell for spending time with us. And I'm going to hand this over to Dennis Tavernetti, who is a member of the Lunch and Learn Committee and who coordinated this event to get us started. Thank you so much.
Thanks, Nancy. Welcome to today's Lunch and Learn. Today's Lunch and Learn is going to be a little bit different than you're used to. Normally, the speaker goes on until 10 minutes before the close of class, and then we get your Q&As. Our speaker would like to change that format, and we discussed it beforehand, that she will give her key points, and that will be about 20 minutes worth, and then we'll go into your questions and answers. So we know there are a lot of questions on everybody's minds, and so we wanted to provide that opportunity as well. Today's speaker is Dr. Linda Bell, who is state epidemiologist and also a key member of South Carolina's Department of Environmental Control, otherwise known as DHEC. I think in layperson's terms, she fulfills a familiar role to Dr. Fossey, who's one of my favorite national guys. And we rely on him, and we can rely on Dr. Bell to give us the COVID-19 information as it relates to the state level. Dr. Bell graduated from University of Texas Medical School with an MD degree. She's been in her current position, I think, for 6 or 7 years with DHEC, and she leads a department of 120 people. And so we're lucky to have her today to do this. On a personal note, I always like to do this. There are 2 MDs in the Bell household, as her husband is a cardiologist. And there is one question I've seen that she is going to answer, but she needs to tell her husband tonight how she answered it, because it has to do with a heart question. For sure, Dr. Bell has, you can well imagine, been fully engaged in our state's attempt to control the virus, to decrease the negative consequences of the virus. And today's goal in this Lunch and Learn is for her to have the opportunity to firsthand communicate the latest on controlling it, in which we all are key players. Clearly, we need to understand the risks and consequences of a do-nothing approach, which would obviously result in a disaster. Likewise, we must understand what it is we can do and need to do, and it needs to be based on expert advice, not some home or political remedy based on zero scientific facts or social media. And all those other things are always fighting for our attention as well. So without further ado, here's Dr. Bell.
Well, thank you so much, Mr. Tavernetti. I really appreciate this invitation. I have some slides prepared, and I hope they will address a number of questions, but maybe they can just be a highlight, and I anticipate there may be some follow-up questions even of what I've presented. So with that, I'm going to share my screen. Could you turn off the volume?
I can't.
And please let me know if you can see the screen. Are you able to see my screen? Okay, great. So I will move through these quickly because I understand the interest may be in the opportunity to ask questions. I want to give some background first. Now, I also ask, I'm going to do my best to project my voice. If you can't hear me well, maybe somebody could just wave and ask me to speak up. But just some background about the surge that we're currently seeing. This slide represents all the cases that have been reported since the first case was recognized in South Carolina on March 1st of 2020. So we've been at this now for almost a year. Just a couple of points about this slide. These bars, the blue bars, represent the number of confirmed cases in South Carolina. And we currently have over 250,000, actually more than 300,000 confirmed cases in South Carolina now. And the other point, 2 points about this slide that I want to make is that we look at this spike that occurred following the 4th of July weekend. This was a time when public health officials were very concerned about the surge, and the number of cases at that time was very concerning. If you compare that to what we're experiencing here now, I don't have to, I cannot overstate how much greater the problem is now, how much greater the surge is now than what we were experiencing early on. And we certainly hope to be in a much better position now than we thought we would be back then. However, the next point I want to make about this slide is this green line, which represents the 7-day moving average of cases. And there is encouragement here in the fact that we are looking at this downward trend in this green line. So for at least 7 days now, we here in South Carolina and actually nationally, we are experiencing a downward trend. And we hope that that continues. I will say, however, that although cases are declining and hospitalizations are declining, deaths are continuing to increase because there is a delay in deaths, because once an individual is hospitalized, it may take some time for the course of their illness to play out where they either recover or unfortunately die. So this is important information to tell us that after these previous surges and declines, when some of us may have let up on our prevention measures, now is not the time to do that. We need to continue to see this curve decline and reach a point where we are seeing levels of transmission that will represent what we saw back in the beginning in 2020. So what actions are needed now? I have to emphasize, do not relax the current prevention measures. And I'm sure that all of you could repeat these. You don't need me to say this. But what I want to emphasize is not just the use of masks, but it is the consistent and correct use of masks. I know some people sort of haphazardly use them. And while we have disease rates that are so high in the community, if you don't do it consistently, you increase your risk of exposure. The other point I want to make is the correct use of a mask, that it must cover your nose and your mouth to prevent you from inhaling respiratory droplets, and then it must be a well-fitted mask, and that it should be constructed of at least 2 layers of fabric. So there are some masks available that do not offer good protection. They're more of a fashion statement, and I tell you, you should choose function over fashion. The other thing is to get tested based on your activities and your risk of exposure. We recommend for most people who are out in the community that they consider being tested at least once a month. If you're out in the community more often than that, or you believe you've been in a setting or exposed to someone specifically, then you should get tested based on your risk of exposure. Be careful and thoughtful about safe gatherings. You should ask yourself if you're going to participate in something, and if you have any hesitancy as to whether or not that's safe, you should probably give that a second thought, because we see groups where transmission occurs, and we also want you to be mindful of transmission from family members and friends in your household. We see clusters of transmission very frequently in households, and people tend to let down their guards when they're around people that they know well and their friends. They don't believe that your family, your loved ones, and your friends can transmit the virus, but this is one of the most common ways of transmission. And then I'll spend the bulk of my presentation on getting vaccinated when indicated. So just a few words about the vaccine. The 2 vaccines that are currently available, the Moderna and the Pfizer vaccines, are based on the messenger RNA. This is the genetic material that's contained in the virus. None of these vaccines actually contain the virus itself, so they cannot give you the disease. They cannot transmit the virus itself. The vaccine manufacturers use a little bit of this genetic material to engineer a way for the body to be stimulated to mount an immune response against a piece of this genetic material that creates a protein on the coat of the virus that I'm pointing to here. And it's the body is stimulated to produce what are called B-cell immunity cells, T-cell immunity cells, and antibodies, so that if the actual virus is introduced into your body from natural exposure, your body is primed with these immune cells and antibodies to fight off the virus. I'm going to go through some slides now to answer some of the most frequent questions that I get. And these may be out of order. Actually, maybe I shouldn't have started with who should not get vaccinated. But the point is, the vast majority of people can safely receive this vaccine. So I'll start with who should not get vaccinated, and then that leaves everyone else. And it's only those individuals who have a history of a severe allergic reaction known as anaphylaxis, or an immediate allergic reaction, even if that was not severe, to any ingredient that's in one of these messenger RNA vaccines. And you would know this because a physician would have diagnosed this for you, that you have anaphylaxis. So the vast majority of people who have this history would already know it. If you have any severe allergic reaction after getting the first dose of the vaccine, then you should not receive the second dose of a messenger RNA vaccine. An immediate allergic reaction means a reaction within 4 hours of getting vaccinated and includes symptoms like hives, swelling, or wheezing, or some sort of respiratory distress, difficulty breathing. And then this goes into some of those components. And again, your physician, an allergist, would know whether or not you had reacted to one of these components. So I won't go into that. The next thing is precautions. These are not reasons not to get vaccine, but it is a precaution that if you've had an immediate allergic reaction to any other vaccine or any other injectable drug therapy, and intramuscular injection, intravenous injection, or any other type of injection that's not related to the COVID-19 vaccines, then that is a precaution that you should consult with your healthcare provider about. There are unknown risks of developing a severe allergic reaction, and these should be balanced against the benefit of vaccination. And I'll go into the benefits that far outweigh the risk just in a few minutes. And again, if you have concerns about a previous allergic reaction, then healthcare providers who are providing the vaccines may want to defer your vaccination and have you consult with an allergist or immunologist to get the best advice that is tailored for your specific medical conditions and your potential risks if you have underlying medical problems. So the following things are not contraindications and they are not precautions. And what I mean by this is that anybody who has any of these conditions can be vaccinated. If you have an allergy to food, pets, bee venom, environmental exposures like dust or something like that, oral medications, latex, eggs, or gelatin, you can be vaccinated. These are not contraindications or precautions. For everyone's safety, we recommend that anyone who has a precaution, being a history of anaphylaxis or an allergy to another drug, they must be observed for 30 minutes to make sure that they do not have a reaction. For all other persons, they should be observed for 15 minutes after receiving a vaccine. This is one of the safety measures to make sure that anybody that does have an allergic reaction, and these are quite rare, that they're in a setting where they can receive medical treatment. Another question I get, is one vaccine better than another? So I'm going to lump these two vaccines into one category, the Pfizer and the Moderna vaccine, because these are both the messenger RNA vaccines. They are both approximately 95% effective in preventing severe illness. The safety profiles of both of these vaccines are very similar in all populations, so they were shown to be very safe. The side effects I'll go into in just a second. So there are no implications for safety or protection against disease for these two vaccinations. So there's really no choice to be made between the two for an individual. They only differ in storage and handling that has meaning for the healthcare providers who have to keep these vaccines in a freezer or refrigerator. So there's really no choice there. We are encouraged by the fact that there are other vaccines coming down the pipeline. The first that we believe will soon be submitted by the vaccine manufacturer to the Food and Drug Administration for emergency use authorization is a Johnson & Johnson product. The overall efficacy of this vaccine is a bit lower than the Pfizer and Moderna. However, there are some key points I would like everyone to be aware of. This is the overall efficacy worldwide. The efficacy in the United States was a bit better at 72%. But when we look at efficacy, we are looking at the effectiveness globally against preventing severe COVID-19 illness. And I highlight this because although they may have lower effectiveness in preventing moderate illness, what we're really focused on is their ability to prevent severe illness. And in fact, this vaccine is quite good at that. In South Africa, where the new variant is widespread, that has just been identified in South Carolina, there were no hospitalizations and no deaths reported in those who were vaccinated. So this particular vaccine that will soon be available, I hope, is very effective against preventing hospitalizations and deaths. And that is a very important consideration, because the benefit of this vaccine is that it will be available in a single dose. These other vaccines, the Pfizer and Moderna vaccine, must have a 2-dose series to reach that maximum efficacy, separated by either 3 or 4 weeks. So now I'll discuss the vaccine risks and benefits. I'm going to show you a picture. This is actually the back of my head, picture of me receiving my first dose of the vaccine. I received my second dose 3 days ago. I had a bit of a sore arm, no other side effects. And so what I'm hearing from people when they say they're concerned, I'm going to wait, they don't think it's safe, they want to see more people vaccinated, I want to let you know that as of a few days ago, nearly 28 million doses have been administered in the United States. And there is a system in place by the CDC. It's called the V-Safe system. For any of you who have been vaccinated or who will be vaccinated, you may be asked if you are willing to enroll in this surveillance system where the CDC continues to monitor for the safety profile of these vaccines. And this is what the V-Safe system is. We participate. I got a message every day for the first 6 days after my first 2 shots. Was I having any fever, headache, soreness, anything of the kind? And this is the way they monitor the safety of the vaccine. And after 28 million doses, they have not observed any unexpected side effects. And so the most common side effects are in the arm where you got the shot. Pain, swelling, redness are all expected with all injections. And I experienced a bit of pain. It lasted for about a day. I took a little bit of Tylenol. After that, I really felt fine. Other findings, other side effects that are common in anywhere between 30 and 50% of the people may be chills, achiness, tiredness, headache. These are not adverse events. These are simply your body being stimulated to mount an immune response, and these are expected. The vast majority of these effects in those who experience them, as I said, I didn't have any of these, but they may start a day or two after getting the vaccine, may feel a little like mild flu symptoms, and they may actually inhibit your activities for a day or so. The vast majority go away in a few days. I want to report though on some of this adverse events data. And this is, I just pulled a slide from, this is the Moderna vaccine alone, after the administration of about 4 million doses. What I mentioned about more severe adverse events, because we are aware that adverse events occur not only after these vaccines, but after any drug, any vaccine, this is a possibility. They observed adverse events in only a little over 1,000 people of the 4 million who received the Moderna vaccine. That's 0.03%. Among this 1,000, only 10 of these were identified as severe allergic reactions. That's a rate of severe allergic reaction or anaphylaxis of about 2 per million doses administered. All of these individuals survived with no complications. So this is when I want to talk about the risk of the vaccine, that low, maybe 2 cases per million dose with not any very, very severe outcomes as compared to our risk from COVID-19. What this slide shows is that individuals who have underlying conditions like asthma, hypertension, obesity, diabetes, chronic kidney disease are at a significantly increased risk of being hospitalized. And in fact, any one of these conditions can increase your risk for hospitalization from anywhere from 1.5 times to as much as 3 times for a single condition, or as much as 5 times more likely to be hospitalized if you have any of these conditions. And I know so many members of our population have these underlying conditions. And so the risk of exposure to the disease and for hospitalization is much higher than the risk of allergic reactions from the vaccine. And so the benefit that these vaccines may give us, even if it is only about in the range of 70% protection against severe disease or hospitalization, that is a significant benefit. And I just want to highlight again, I won't spend a lot more time. I'm going to rush through to make sure there are time for questions, that we look at the reported deaths in South Carolina by age, and this is actually broken down by race as well. And we are, our goal is to protect those who are at highest risk of complications with a limited vaccine supply. So this shows the age range where the peak of deaths are in South Carolina, in the range of 75 to 79 and up. Although there is a peak here, and we recognize that even individuals who are middle-aged and up are actually dying from this disease. And it is our goal to vaccinate all who want to be vaccinated as quickly as possible. So there are significant benefits of the vaccine, addressing the mortality. We also want to recognize when people are raising questions about should I be vaccinated or should they take the risk of exposure, that there are really very limited treatment options for COVID-19, that we must achieve widespread vaccination as quickly as possible to be highly effective to control the pandemic for all of us. And I'm going to move now into vaccine planning, that our overarching principle is averting deaths and maximizing the scarce resource. And this is the limiting factor, that there is simply not enough vaccine supply to go around now to meet all of the demand. And we are working to prioritize those at greatest risk. And each day we are giving additional consideration to how we can best use these supplies. I'm getting questions about when will we move through the phases. Currently, we are in phase 1. There are approximately nearly 1 million people in phase 1 to be vaccinated. We receive about 63,000 doses of vaccine a week. So this tells us that it's going to take us many more weeks, probably into March, before we can offer vaccine for the currently defined stages of healthcare workers, long-term care facility residents, any individual who's admitted to a hospital who is age 65 and older who does not have COVID, anyone over the age of 70, and individuals who are doing mission critical work who are at increased risk above the general population for being exposed. We hope to get to phase 1B by early spring. That means moving into March. And we are well aware that these phases, which follow the CDC's recommendations, leave individuals who are 65 years and older, or those with underlying health conditions, in phase 1C, which may take until late spring to get there, because there are approximately 500,000 people in phase 1B and about 2.9 million people in phase 1C. Our hope is that by some means the vaccine supply will increase, allowing us to move more quickly through these phases. And again, we're evaluating who's at risk, vaccine utilization, and community needs to make decisions each day about how we can better meet the demands. I do want to give a perspective on vaccine supply. This is one story, again, about the US drug maker Moderna that has notified countries in Europe about shortfalls below what they had promised to countries like Italy, France, where those countries are expecting 20% fewer vaccines than promised in the week coming. This has to do with their, they rely on some supplies, although this is a US drug manufacturer, they rely on some supplies from Switzerland. This is impacting European countries, but this is also why we in DHEC say that we can't make a lot of projections more than about a week in advance, because we learn from the CDC each Tuesday what our vaccine supply will be for the coming week. And we place our orders for the vaccine supply that's available for our state based on the population each Thursday. And if there's some complication in the supply, then that hinders our ability to schedule appointments and to deliver the vaccine as we expected. And we hope that we will not encounter this in our country. So now I'll talk for just a few minutes about our vaccine locator. This is a screenshot. I took a picture of what's on our vaccine website. This is an interactive map that you can find on the DHEC website. And we know that there may be some challenges for some people accessing this map. You may want to get family members or friends to help you with this vaccine locator. And what I'll quickly explain is that all of these sites, whether they are red or green, are currently offering vaccinations. However, it is only the green circles that are currently offering appointments. So the red squares are vaccinating, but they do not have appointments. You can hover, you can actually zoom in on this map to find places closest to where you live. And if you hover over, and I've frozen one here, I just happen to hover over one on the coast, which tells you the address. It tells you that it is a Publix pharmacy, and it gives you a website. So DHEC will not be making these appointments per se, but you'll be able to call each location and find out, do they have vaccines available? However, we did recently, as of last Friday, open up a new vaccine information line. As opposed to our previous care line, it was only staffed by about 30 or 40 people, and it was very challenging to get through on that line. This new vaccine information line is staffed by nearly 300 people. So the hope is that we will be able to offer assistance more readily with more support in finding appointments for the vaccine. We're actually also launching a new vaccination appointment line. But this number, and I will jot this down and put it in the chat box so you can capture it. The number for the new line is 866-365-8110. That's the number you can call, and people will assist those who do not have computer access in navigating to assistance with finding an appointment. The next thing I do want to say, though, is that the limitation is in vaccine supply. So even though we may have more assistance in making appointments, we still have the limitation. But South Carolina currently ranks 5th in the nation for COVID-19 vaccine use for the second consecutive week. So this means that for the vaccine received in the state, we are using nearly 78%, actually nearly 80% of the total doses available to us. So we are in the top 5 in the nation in delivering vaccine. And the disappointment again is that there is just not enough vaccine currently to meet the demand. But we've received 560,000 doses, and 539,000 of those shots have been administered. I think this is one of my final slides that I want to bring to this audience's attention, to please beware of vaccine-related scams. Beware of scammers who may call, especially older individuals, using the vaccine rollout as a ploy to steal private information or to steal money. Please know that vaccine providers will not call and ask for personal information. Only share personal information with an approved vaccine provider if you are actually making an appointment. Do not give information to anyone else if you are not making an appointment. Do not pay for or provide information to join a wait list to get early access. That may be a means to get money, and no legitimate person is asking for payment to get on a wait list. A list of approved vaccine providers can be found on DHEC's website. I have a few slides about the variant that's been identified, but I think I'll stop here to allow for questions, and I can address those if they come up. And so I'll stop there and allow for questions. I'll stop sharing my screen.
I have a question. My youngest daughter is very concerned about their 2-year-old toddler. At what point will children of that age be safe to go out, whether it's that they have a vaccine or that so many people have been vaccinated that there is relative safety that they can be out in the world.
Of course. So until we reach the low levels of disease that I mentioned on my first slide, I would say that it's really not safe for any of us to go out in public without these prevention measures. Now, for a child who's under the age of 2, a mask is not recommended. So the parents of a young child would have to pay special attention to protecting that child from group settings, maintaining physical distance of 6 feet. And as far as the vaccination, the currently available vaccinations have not been tested in individuals under the age of 16. So we expect that it's going to be quite some time before individuals under 16 will be eligible to be vaccinated. So we must all, in the meantime, continue to observe those prevention measures with the masks, physical distancing, avoiding gatherings, and special attention to young children, because masks can be problematic for them. They adjust them too much, they don't wear them consistently, and it's not a good means of protection for young children.
Thank you. Just let's remember that we're not taking oral chat questions. I'm going to moderate and go through so we can consolidate some of the things. So thank you for that question. And thank you, Doctor, for answering it. Some of the questions that we have here relate to the VAMS sign-up process, which is difficult. Dr. Bell, you've already talked to the point of not everybody has a computer and so on. I understand that the VAMS process was going to be revamped. Is that going to happen soon?
Yes, we are actually not revamping the VAMS system. We are replacing it with a different appointment system. And we are launching that system as we speak in a sort of a trial for appointments just in our DHEC public health clinics. And as we look at any potential glitches or anything like that before we roll it out to all other providers, we believe that that vaccine appointment system will be much simpler and will be much more user-friendly. And so we expect that it will be available to the general public. Well, it's available to the general public now for appointments in DHEC clinics, but it will be available for appointments in all other providers very soon. So we at DHEC do not like the VAMS system at all either.
Okay, there's another string of questions about people that have gotten their first shot and have even made their appointment for their booster or second shot, but they're concerned about the availability of vaccine for them when their time comes up because they want to meet their window. And they were wondering if there is a priority in South Carolina, I guess, for honoring the second booster ahead of new firsts.
So what we're doing to address that is we're asking all providers when they administer the first dose to go ahead and make an appointment for the individual for their second dose. The other thing is that if the second dose appointment does not fall within that window for Pfizer vaccine of 3 weeks or the Moderna vaccine of 4 weeks, it's perfectly fine to receive the vaccine as early as 4 days prior to that window or for as long as 6 weeks after. So it doesn't affect the immune response, and you would not have to start the series over if you are not able to get your second dose appointment within that 3 or 4 week period. So we are asking providers to make sure to do their best they can to make sure that they have a second appointment at the time they schedule the first. It's not a significant problem if you have to go a bit outside of that window.
Okay, the other question is that people are understanding the mutations and they're wondering whether they should wait to have the first vaccination because maybe the vaccine will be altered and changed to capture the mutations. Should they wait?
No, I do not advise waiting. As soon as someone can get an appointment for the vaccine when they're eligible, I encourage them to go ahead and do it for these reasons. Currently, the available vaccines have been shown to be effective against the variant strains that are circulating. This is the UK strain. There may be some diminished protection they're continuing to study that, but the most commonly circulating strain in the United States right now are not these variant strains. So we want all individuals to take the opportunity to be protected against the most common strains. These other vaccines that are coming, they're also testing the effectiveness against the variant strains. And they are looking at the possibility of tweaking these vaccines to make sure that they react against those protein coats that I mentioned. So in short, when a vaccine becomes available to you, go ahead and get it now, because the exposure risk is currently high and you want that protection as soon as possible. Please don't wait.
We have a host of questions because we must have a young group here who are 65. And they are wondering when they would be able to get vaccine, and they're adding to that. They believe that the president has recently gone on record that all states should be vaccinating 65 and above. And they don't understand. They have some friends in other states that are vaccinating now at 65.
Yes, and we're aware of that. We are continuing to follow the CDC guidelines, but different states did different rollouts. For example, in South Carolina, we made sure that all nursing home residents were vaccinated in the first few weeks, and we're almost complete with second doses for all those nursing homes. If we add the 65 and above, which we very much want to do, putting more individuals into an earlier phase doesn't necessarily mean that they will get vaccinated any earlier, because the limitation will still be on the vaccine supply. So even if we give higher priority to 65-year-olds, we will still be getting roughly 63,000 doses of vaccine a week for the foreseeable future. So it will still complicate getting an appointment, and it doesn't mean that they would get vaccinated any earlier, but we're hoping that more doses will be coming forward, that vaccine production will ramp up. But we, as far as I'm concerned, would like to have everybody in phase 1A, but that does not mean that they would receive vaccine.
So currently, with the current vaccine supply for South Carolina, I think you said late spring.
So to move through phase 1A, we anticipate it will take us into early March, and then moving through phase 1B, we believe that will take us into late spring. And I just want to emphasize that we are trying to reach those at the most significant risk of exposure first. So there can be younger frontline workers who do shift work and they're continuously exposed to the virus, as opposed to other individuals who are actually more isolated. And we want to protect those workers. We want to protect the healthcare system so that they can continue to provide services for all of us.
Okay, a question on the reactions, which you explained, what the reactions were. The person is asking if the stronger the reaction, does that mean that our system is making us actually more protective than if we get hardly any reaction at all?
You know, that's a great question. And I can't say that there is a correlation, because when they test the response for people who have mild reactions or no reactions, and they're looking at the effectiveness of the vaccine, it actually includes all individuals. So there are, I would say a majority of people do not have those side effects of achiness, fever, headache, and so forth. But the protectiveness of the vaccine at about 95% covers that entire population. So if you don't have achiness, fever, so forth, that does not mean that your body is not mounting an immune response.
Okay, I guess one question is, we're sort of used to having the flu shot every year. Are we going to have a COVID-19 shot every year?
another great question. I thank you for that. And we don't have a long enough track record with the COVID vaccines. They've only been administered now for just a few short months. And so the public health officials and researchers will continue to study whether or not there is long-standing immunity provided by these vaccines, or the possibility that we may have to get annual doses of the vaccine. And this might particularly be a possibility if these COVID viruses continue to mutate and there are different strains that circulate. This is exactly what happens with the flu virus each year. The strains are a little different, and so we have to get a vaccine that's well matched to the current circulating strain. And we will see if these vaccines give us long-term protection beyond the months to come.
You made some comments about effective placement of masks and having a multiple layer mask. There's been some talk recently in media that maybe 2 masks are better than 1. What do you think?
Well, I happened to be on a national call with some CDC experts actually yesterday, and that question came up, asking the CDC when would they speak to whether or not 2 masks are more effective. And so the CDC is not currently recommending 2 masks. However, they did say, speak to the importance of a well-fitted mask, that if you're wearing a mask that has gaps around the face, that doesn't offer ideal protection against the entry of the virus. It should be 2 layers of woven fabric. It is good to have a mask. Many of them are manufactured that have a pocket in the middle where you can put a little filter in there, sort of like a coffee filter, to give a 3rd layer of protection. So the use of 2 masks, there's not strong evidence right now to say that that's better than a single double layer, well-fitted mask that is consistently and correctly used over the nose and mouth.
Okay, related to that, people are generally surprised and wonder about the requirements once they are vaccinated and a certain number of days go by. So they are protected from COVID-19, having been vaccinated and giving your body time in order to protect itself. And they wonder why it is that you folks are insisting that they continue to wear a mask and practice social distancing and frequently washing your hands, even if they've had the vaccine. Isn't the virus dead?
So this is a very important point. The vaccines work to prevent severe illness and hospitalization. And that is our goal in preventing hospitalizations and deaths. However, the vaccines are not yet known to prevent against infection. So many of you may be aware that a large number of individuals have no symptoms whatsoever, but they can still spread the virus. This is also true for individuals who are vaccinated. So although they're protected against severe disease and hospitalization, they can still be infected. They themselves will not get sick, but they can spread the virus unknowingly to others. And that is why we must still continue to practice those prevention measures until disease rates in the community as a whole fall to a very low level, until we get to that herd immunity. We don't yet know that vaccines prevent against infection, but they're great against protection against illness and hospitalizations and deaths.
There are quite a few questions which surprised me regarding people that have had COVID-19, and that's been confirmed by antibodies, perhaps, or in their body. They've been tested and has come back as being positive. The question for them, by them, is should they be vaccinated?
Yes, individuals who have had COVID should still be vaccinated, because we believe that immunity, the protection from the vaccine, will last longer than protection against natural disease. We are aware that some people can get reinfected, they can get COVID a second time. That is only known to occur more than 90 days after the first infection. But what it tells us is that we need to be vaccinated to prevent those second infections. And there may still even be breakthrough disease among those vaccinated. But there are more studies that are ongoing from the CDC to look at how long immunity lasts and how effective it is in all populations.
Some people were watching your slides, and a question has come up. Why is it we're not administering 100% of the vaccine that has been allocated? That we're running around 78 or 80%, I think, is what you showed. So they're wondering what the disconnect is and why that is.
All that has to do with is lag time, because providers have to have vaccine on hand in order to honor the appointments that have been scheduled. So it means that there are doses in providers' offices for people who have scheduled appointments. So you will never see 100% utilization as long as we're making appointments, and they have to hold on to those doses to make sure that they can honor those appointments and to make sure that they have doses available for the second dose. So it doesn't mean that anybody is sitting on inventory that does not have a designated use planned in the near future.
I just heard that the CDC have just issued a national mandate to wear face masks on all public transportation. Are you hopeful that this will be accepted by the masses?
I'm extremely hopeful. This is the as we look at the concerns about the availability of vaccine and how so many who are at risk have to wait. What we have said all along is that we have a tool at our disposal that has been available to all of us throughout this pandemic. And the fact that everyone was not consistently and correctly using the masks and practicing the physical distancing, the good hygiene has been my concern throughout this pandemic. So we have looked to community leaders to implement mask ordinances and to enforce those for the protection of the community as a whole. And transportation hubs are a big risk. They bring together lots of people who are in close proximity, especially when you're traveling on any commercial conveyance. And now that we are looking at the introduction of these variants that are more easily spread than others, we have to really pay careful attention to travel and protection against exposure from travelers and the introduction of these variants here in our population. But also, we still very much need everyone to continue to wear these masks. And so I'm hopeful that that coming down from the administration, those requirements sort of takes away the option that many travelers opted not to wear the masks. Airlines gave them the option to do that, and they were not required in transportation hubs. This is a very important prevention measure that we will all benefit from.
We have some questions from people who have applied to a local pharmacy, one of the green spots, and 5 or 6 days has gone by and they haven't heard back. The question is, should they apply to other locations as well?
I think as long as you do not have an appointment in the VAM system, if you're just waiting for a callback, then you can certainly look around. Now, if you have an appointment already in the system, if you attempt to make another appointment, you may get kicked out. So that's something I caution someone against, losing an appointment that you already have to try and get an earlier slot. And that might be something that you should call the DHEC helpline. I think I put that in the chat box. I forgot to push send. I just put in the chat box that this is the number for DHEC's new vaccine assistance line, so that if they have questions like that, specific assistance, they can call for help.
Okay. Someone else is asking how long after the second dose, how many days will you be at peak protection?
It takes about 1 to 2 weeks for your body to mount the optimal immune response. That can vary from one individual to the next. For example, some individuals may have a weakened immune system. They may not have as robust a response. But generally, after 2 weeks, they should have the protection against severe disease from the vaccine.
You mentioned a lot of discussion about other vaccines coming along. And obviously the J&J one, which is a single dose and doesn't require significant logistics problems with freezing and so on, is going to be widely used, particularly in those countries that don't have good distribution systems. And but its ability to protect is maybe somewhat less, or a lot less, depending on how you look at it, in protection. I think, should people be concerned about that? If I don't know what's going to happen in the United States as far as that being has been approved yet by the FDA, but should it be approved by the FDA and it be able to relieve the shortage of vaccine? Would you be all for people taking that in order to get people vaccine with significant protection for severe COVID damage, or not?
I actually would encourage vaccination with that J&J product or other vaccines that have that efficacy in that range. And for this reason, I neglected to mention this earlier. People may not be aware that when we give the annual flu vaccine, the efficacy of those flu vaccines ranges anywhere from about 40 to 80%, depending on how well matched it is with the predominant circulating strain and an individual's immune response. So we have always spoken to the effectiveness of flu vaccines in not necessarily preventing disease, because you can get the vaccine and you can still get the flu. But similarly, flu vaccines are also very effective in preventing hospitalizations and deaths. So this is a great example and a great analogy for a vaccine that we have similarly used for years and years to prevent hospitalizations and deaths. And so we would also be looking at this J&J vaccine in the same range. I think it's a great option, and it will increase our vaccine supply. It will be simpler for many providers, and it will be simpler for many people to get a good amount of protection with a single dose.
Okay, another question about increasing availability of locations for vaccinations. The one person is asking a question that it's moving to other retail outlets, which I presume are pharmacies in grocery markets, for examples, or even pharmacies themselves. I think in South Carolina, our pharmacies have been busy vaccinating nursing homes and as well as medical personnel. But we are starting to see, I think Publix just announced they're going to do vaccination. The person who asked the question has a concern that will these people be trained adequately who are going to be dispensing and mixing the vaccine, even though they're not in the normal hospital venue?
Yes, absolutely. No one in South Carolina is authorized to provide a vaccine who has not met the training criteria to administer the vaccine. So this applies to all nurses, all physicians, all pharmacists, pharmacy techs. In order to get the vaccine out as quickly as possible, we are deploying as many health professionals as we can. But they must all first meet their requirements for training and be able to demonstrate that they are proficient in vaccinating. So that should not be a concern. Any clinic that is offering a vaccine will have medical providers who are trained and proficient in administering the vaccine.
We have two sort of personal questions, but I think they're worthwhile because they may apply to more people. This one individual has a father who is 85 years old, and he has AFib from a pre-existing health conditions, and he's 85, and he had his first shot vaccine and had a very rapid heartbeat after taking the vaccine, and he stayed obviously at the vaccination site for about 35 minutes, and then it self-corrected, and he was able to go home, and he's been fine ever since, but it scared him. Additionally, now he's wondering about is coming up time for his second shot, and he heard from another friend that had a similar problem and experienced a very rapid heartbeat of 130, and it took that person a long time to settle down. He asked his cardiologist, this is why this is the one you get to talk to your husband about when you get home. The cardiologist said, well, yeah, you should go ahead and have the second shot. What would you recommend from advice to this person?
Well, I'm married to a cardiologist. I'm not a cardiologist. But what I would say is that individuals should follow the advice of their providers. Because I would have several questions. Are these individuals who periodically have episodes of, their heart racing or breakthrough with their AFib or aflutter that could be actually coincidental but not associated with the shot? And that's the one of the primary questions. So, what triggers any episodes that they're having? And if their cardiologist has advised and is familiar with their baseline and whatnot that they should get the second shot, then they should follow their cardiologist's advice. I'm not aware of a correlation between the shots and inducing other AFib or aflutter, but they should follow their individual provider's advice if they have those questions.
Okay.
Husband tonight, if I got that right.
I understand that COVID-19 impacts differently on different ethnic groups. And it can be more severe than our primary ethnic group of Caucasians. And also the challenge is that those particular groups may be more difficult to communicate with and to be comfortable with taking a shot. They're more resistant, in other words, to follow the advice. And then we have rural populations as well in South Carolina, and which is quite a challenge as well for vaccine distribution, as well as providing vaccine shots to the rural population. How is DHEC approaching these folks who we do want to protect?
Yes, thank you for that question. And I want to address one thing first. It's not that African Americans, Latino populations, Native Americans, and so forth are more genetically predisposed to complications. It's that in these individuals who are more likely to have underlying conditions that put them at increased risk
Yes. Mm-hmm.
of suffering complications. So it's actually the pre-existing conditions. And in addition to that, they may be more likely to be exposed because of the community conditions that they live and work in. So they're at higher risk for exposure, at higher risk for complications for those reasons. And what DHEC is doing to address limited access to care that has plagued these communities for long prior to COVID is making sure that we are partnering with providers that serve these communities and making sure that we are strategically putting vaccine doses in practices, in chain pharmacies, in independent pharmacies, rural health practices, and community health centers that serve those needs in those underserved communities. And we also have a communications campaign to make sure that we reach out to individuals in these communities who have vaccine hesitancy to explain many of the things that I hope I explained here about why the vaccine, about how the vaccine works, about the evidence that we have that shows that it's safe, that it's gone through very rigid research protocols to establish that safety and effectiveness. And most importantly, to explain to these communities that their risk of exposure, their risk of hospitalizations and death being much higher than the general population is one of the main reasons that they really need to focus on the benefit of the vaccine. And my hope is to lessen their concerns about any concerns about safety, reactions, and quite frankly, a number of myths about the vaccine, so that we want them to realize the full benefit of protection that's available to them when they can get the shot.
Well, okay, our time is up. Dr. Bell, thank you so much for sharing. This has been, I think it's been very helpful. We're very appreciative. And thank you again.
Thank you so much for the invitation.
Thank you so much. It was wonderful.